is development of foregut and anomalies. So in this we study the competency, that is development and congenital anomalies of the foregut. Foregut derivatives are pharynx and its derivatives, lower respiratory tract, esophagus, stomach, duodenum as far as the entrance of the common bile duct, liver, pancreas, biliary apparatus, all except for the pharynx, respiratory tract and upper esophagus are supplied by the celiac artery. Foregut caudal segment. Esophagus is partitioned from trachea by tracheoesophageal septum. Esophagus is initially very short but elongates rapidly, reaching its final relative length by about week 7. Elongation is a result of cranial body growth, that is ascent of the pharynx. Endoderm of the esophagus initially proliferates and almost obliterates the lumen but recanalizes near the end of the embryonic period. Striated muscle in the upper 2/3 of the esophagus is derived from the mesenchyme of the caudal bronchial arches. So it is innervated by cranial nerve 10, that is vagus, through accessory nerve. Smooth muscle in the lower third of the esophagus develops from the surrounding splanchnic mesenchyme and innervated by visceral nerve. Splanchnic plexus derived from neural crest cells. Stomach first appears as a fusiform dilatation of the caudal portion of the foregut. The primordial soon enlarges and broadens dorsoventrally. Its position and appearance change as a result of different rates of growth in various regions of its wall, as well as changes in the position of the surrounding structures. Postal changes are explained most easily by assuming that the stomach rotates a longitudinal and an anteroposterior axis. Around the longitudinal axis, the stomach carries out a 90-degree clockwise rotation, causing its left side to face anteriorly and the right side posteriorly. Anteroposterior axis rotation displaces the pyloric part of stomach to the right and upward and the cardiac part to the left and downward. Dorsal border of stomach grows faster than the ventral and produces the greater and lesser curvature of the stomach. A stomach is attached to the posterior body wall by dorsal mesogastrium. Longitudinal rotation pulls the dorsal mesogastrium to the left and helps form the omental bursa or the lesser sac. As the embryo lengthens, the caudal part of the septum transversum thins and becomes the ventral mesentery or the mesogastrium. It attaches the stomach and duodenum to the ventral wall of the abdominal cavity. Omental bursa. Clefts appear between the cells of the dorsal mesogastrium, which coalesce and eventually form a single cavity, that is omental bursa. Cavity expands in all directions and come to lie behind the stomach. Omental bursa. As the stomach enlarges, the lesser sac expands into an inferior recess which forms between the layers of the elongating dorsal mesogastrium. 4-layered greater omentum overhangs the developing small intestines. Most of the inferior recess of the lesser sac disappears as the layers of the greater omentum fuse. Omental bursa communicates with greater sac by way of epiploic foramen or foramen of Winslow. Duodenum. Duodenum forms from the terminal part of the foregut and the cephalic and the cranial portions of the midgut. Two parts grow rapidly and form a C-shaped loop. The junction of the foregut and the midgut is at the apex of this embryonic loop, just distal to the origin of the liver bud. As a result, the duodenum is supplied by branches of both celiac and superior mesenteric arteries. As the stomach rotates, the duodenum also rotates to the right and comes to lie retroperitoneally. Liver and biliary apparatus. Their primordium appears at about week 3 as an anterior bud from the endodermal epithelium or the most distal part of the foregut. Hepatic diverticulum consists of rapidly proliferating cell strands. They penetrate septum transversum, where it enlarges and divides into two parts. Larger cranial part is liver primordium. Proliferating cells form cords of liver cells or a hepatic parenchyma, and the epithelial lining of the intrahepatic portion of the biliary apparatus. As the cords penetrate the septum transversum, they cause fragmentation of the umbilical and vitelline veins supplying the liver, resulting in the formation of hepatic sinusoids. The fibrous and hemopoietic tissue and the Kupffer cells are derived from the splanchnic mesenchyme of the septum transversum. The smaller caudal portion of the diverticulum expands to form the gallbladder and the cystic duct. Ventral mesentery. The ventral mesentery is a thin double-layered mesodermal membrane which gives rise to three structures. Lesser omentum lying between the liver and the ventral borders of stomach and duodenum. Falciform ligament between the liver and the anterior abdominal wall. Then visceral peritoneum of the liver that covers the liver except for the barrier of the liver. Pancreas makes its appearance in week 5 as two buds originating from endodermal epithelium of the duodenum. A dorsal bud and a ventral bud. Large dorsal bud appears first and rapidly grows into dorsal mesentery. The dorsal bud forms the major portion of the pancreas, namely the upper half of the head, the isthmus, body and the tail. Ventral bud develops near the entry of the common bile duct into the duodenum. When the duodenum grows and rotates to the right clockwise and becomes C-shaped. Ventral pancreatic bud is carried dorsally along with the common bile duct and comes to lie immediately below and behind the dorsal bud. The parenchyma and the duct system of the both buds then fuse. The ventral bud forms the uncinate process and the inferior part of head of pancreas. Pancreatic ducts. As the pancreatic buds fuse their ducts anastomose, the main pancreatic duct of Wilson forms from the duct of the ventral bud and the distal part of the duct of the dorsal bud. Proximal portion of the duct of the dorsal part often persists as accessory pancreatic duct or also called Santorini, that opens just above the main duct. Ampulla fata, the common bile duct and the duct of the Wilson open into ampulla fata in the second part of duodenum, either together or separately, with the bile duct above the pancreatic duct. Spleen. Spleen obtains its characteristic shape early in the fetal period as a result of rotation of the stomach. Left surface of the dorsal mesogastrium fuses with the peritoneum over the left kidney, accounting for the dorsal attachment of the lienorenal ligament connecting spleen to the left kidney. The mesenchymal cells differentiate to form splenic capsule, the connective tissue, framework of the spleen and its parenchyma. Foregut malformations. Esophageal atresia and stenosis. Esophageal atresia and stenosis occurs often occurs with the tracheoesophageal fistula but may occur independently. That is rare. Atresia stenosis is due to unequal division of the foregut into respiratory and digestive parts or failure of the esophageal recanalization. In esophageal atresia, amniotic fluid cannot enter the intestine for absorption and transfer to the placenta for removal, resulting in polyhydramnios or excess amniotic fluid. Pyloric stenosis is a reduced lumen of the pylorus due to the hypertrophy of the sphincter of the muscle layers. Its cause is unknown but may be genetic. It is the most common abnormality of the stomach in infants, develops in fetal life, occurs in about 1 in 200 males and 1 in 1000 females. The extreme narrowing of the pyloric lumen obstructs the passage of the food, resulting in severe progressive vomiting. Atresia of the gallbladder and bile ducts. Atresia of the gallbladder and bile ducts is the most common serious malformation of the extrahepatic biliary system and is seen in 1 in 20,000 births. It results from persistence of the solid stage of the duct and gallbladder development. The bladder remains atretic and the ducts appear as narrow and fibrous cords. Atresia of the gallbladder and bile ducts. Atresia may be limited to only a small part of the common bile duct, leading to distension of the gallbladder and hepatic duct, resulting in a severe, steadily increasing jaundice after birth. Sometimes duplication, partial subdivision, and diverticular of the gallbladder are also seen. Liver malformations are variations in lobulation, but gross malformations are rare. Variations of the hepatic duct, common bile ducts, and cystic ducts are common. Pancreatic malformations. Accessory pancreatic tissue may be found anywhere from the distal esophagus to the tip of the primary intestinal loop. It is seen most frequently in the wall of the stomach or duodenum or in Meckel's diverticulum. Annular pancreas is a rare malformation consisting of a thin, flat band of pancreatic tissue surrounding the second portion of the duodenum. It may be symptomless but may also constrict the duodenum and result in an obstruction, probably caused by the growth of the bifid ventral pancreatic bud around the duodenum, which fuses with the dorsal bud to form the ring. Thank you.